I will be talking about the right atrial hypertrophy. These are two atrias which are located above the ventricles. This is right atrium, this is left atrium. SA node is located in the right atrium, and when both of these atria depolarize, they generate a P wave on the PQRS complex. Now this is the P wave, and this P wave is generated by depolarization of right and the left atria. Now there is a very important point, because SA node is located in the right atrium, so when it automatically fire impulses, it causes the depolarization of the right atrium before the depolarization of the left atrium. So this P wave is actually has got two portions, first half and the second half. First half of the P wave is generated by the depolarization of the right atrium, and second portion or the second half of the P wave is generated by depolarization of the left atrium. And we check the status of the P wave when we talk about right or left atrial hypertrophy in the rhythm lead. There are two rhythm leads. One is lead 2, which is a limb lead and is located between left foot and right arm. This is lead 2, this is bipolar limb lead, and it is recording the electrical activity very close to both the atria and SA node. So normally we call it lead 2 rhythm lead. If we do not use lead 2 as the rhythm lead, we have an option of chest lead V1, because chest lead V1 is located in the fourth intercostal space on the right side of the sternum. This is also very close to both the atria and the SA node. So two things are very important. First, P actually has got two portions. First is made by the depolarization of the right atrium, and second half is made by the depolarization of the left atrium. Secondly, they lead 2 is the rhythm lead and lead V1. If I make lead 2, this is like it, and if I make lead V1, it is like this. So we can use either of the two. Its upper part is made by the right atrium depolarization and lower part by the left atrial depolarization. But in case of the lead 2, first half is made by the right atrial depolarization and second half is made by the left atrial depolarization. Now normally, if we talk about the lead 2, the height of the P wave in the lead 2 is less than 2.5 millimeter or less than 2.5 small boxes, because we know that in a large box there are 5 small boxes and height of one small box is 1 millimeter. So height of 2.5 small boxes would be 2.5 millimeter. So normally the height of P wave in lead 2 is less than 2.5 millimeter. But whenever there is a right atrial hypertrophy, for example, most of the time it is in cases of the pulmonary hypertension, which can be primary pulmonary hypertension, which can be because of the lungs problem as a secondary pulmonary hypertension, or in cases of the tricuspid regurgitation, there would be right atrial hypertrophy. And when right atrial hypertrophy happens, it affects P wave in a very particular way, that first part of the P wave actually gains a height more than 2.5 millimeter, and it comes back for the left atrial depolarization. This P wave is known as tall, tented or peaked P wave, and the second name is P pulmonale, because most of the time it occurs or happens in cases of the pulmonary hypertension. So this is known as P pulmonale, and it signifies the presence of right atrial hypertrophy. So whenever you check lead 2, which is a rhythm lead, and there you see a P wave whose height is more than 2.5 small boxes, that is known as P pulmonale, and it shows that the patient has got right atrial hypertrophy. We can also check lead V1 if we have no lead 2, but the morphology of the P wave in lead V1 would be like this. First I make normal. This is normal V1. And look at this P, it's not that significant, first portion and second. First portion is because of the right atrial depolarization, and second portion or the downward portion is because of the left atrial depolarization. In case of right atrial hypertrophy, the first portion would be very prominent. And if I make another lead V1 of pulmonary right atrial hypertrophy, it would be like this. Second portion would remain the same. Second portion would remain of the same depth, but the height of the first portion would be more than the usual or the normal. This is lead V1 in case of right atrial hypertrophy. Now, if you look at this example, here you see that in lead 2, P is tented P wave. P is tall, it's peaked P wave, and its height has gone more than 2.5 small boxes or 2.5 millimeter. This is known as P pulmonale because of its association with the pulmonary hypertension, and the importance of presence of this peaked P wave in rhythm lead is that it's because of the right atrial hypertrophy.